Well, hello everyone. Thank you so much for joining us. Today we are talking about JIA and positive ANA, and in the setting of JIA, which is Juvenile Inflammatory Arthritis. And to do so, we have a specialist in JIA, and she's a pediatric rheumatologist. Her name is Dr. Saimun Singla. She is based in Texas, and you are absolutely going to love her. We are going to talk about what JIA is, but we're also going to talk about what it means to have a positive ANA in this setting. And then finally, you will learn about positive ANA in the pediatric world. So, Dr. Singla, thank you so much for being here.
Absolutely.
And yeah, you are seeing patients in Texas. Where at?
Yes. So I am in Houston, Texas. So right outside the medical center here, we have a huge medical center. And the name of my practice is Room to Grow. So I do pediatric autoimmune inflammatory conditions. And in the world of pediatric rheumatology, JIA or juvenile idiopathic arthritis is the most common thing that we see by far. If it's not diagnosing it, it's ruling it out or kind of monitoring for it. So yes, this is our bread and butter, shall we say.
Yeah, perfect. Yeah, you're the specialist. And just so that everyone knows, you have been in academic practice like I
Mhm,
was, right?
mhm.
For a very long time. Is
Yeah,
that correct?
that's right. Prior to kind of venturing on my own, I was in academics at a large children's hospital here, and where I trained, I stayed on as faculty. So you get to see, when you're at a big academic center, you see a lot of different types of disease, severity of disease. So it's given me a great breadth of experience in terms of what JIA looks like, what it doesn't look like. And then because I did the integrative medicine side of things after my own RA diagnosis, now I find that it's very important not just to educate on the medical aspects of it, but also how to manage it in real life. You know that from being a breast cancer survivor. It's like the doctor's visit is this big and everything else takes up this much time, like figuring out when to take your meds, what to eat, how are you
Yep.
supposed to travel with it, all the logistical stuff you don't have time to ask. So that's how that was the birth of Room to Grow. And I was like, you know what, I think we could do this differently. So now
Yeah.
we're 2.5 years in and we're still here. So that's good.
And you're doing great things. So
Thank
thank
you.
you so much. And so tell us about JIA. So what is JIA?
Yeah, so juvenile idiopathic arthritis is a form of childhood arthritis. And the first thing you probably think of is kids can't have arthritis. It's an old people disease. Absolutely not true. I've seen like toddlers as young as 15 months, 12 months get juvenile arthritis. And the I in JIA idiopathic just means that we don't know what causes it. It's not like a known anything like a trigger. We know we have some ideas, but what we think is that you're born into this world with a certain set of genes, obviously family history of autoimmune disease maybe, and there's some sort of trigger that makes those genes kind of unfold. And that could be anything from infections, it can be environmental, it can be getting sick even months ago, and then now all of a sudden you're presenting with swelling. We'll never probably be able to figure out what the exact cause is because it's such a big ball of gooey wax, and like every way you look at it, it might lead to a different answer. But what we do know is that it leads to inflammation in the joint space that's not due to an infection, that's not due to a trauma, and it causes swelling, it causes stiffness, meaning you feel stuck in the morning, and it causes you to just overall be inflamed, inappropriately inflamed. And in children, that's very important because joints are growing, they're developing, the growth plate is open. So if you don't get in there and treat these kind of conditions fast, it can have a lot of consequences, physical to emotional to developmental. And I do want to mention that JIA is just this umbrella term, but there's multiple different subtypes of JIA. So not every child with juvenile arthritis is going to look the same. Everyone's story is different. So basically, we classify it based on the number of joints you have. So oligo is, less than 5 joint involvement. Your polyarticular is going to be more than 4, 5 or more joint involvement. There's other types as well, like enthesitis related, psoriatic arthritis, systemic onset JIA. We kind of match what's going on with you into one of those categories, because most children will fall into one of those categories. A few don't, and they go into this undifferentiated one. But either way, the thing is that you have inappropriate inflammation that's attacking the joints, and we have to get rid of that.
Yeah, that's really interesting. And so how does it present usually? And you said that it can present very various way, but when should someone be concerned about JIA?
So that's a great question because, growing pains in GIA, it can be kind of confusing. So red flags that I would say is that your child is persistently complaining of pain in a certain joint. So sometimes when they say, oh, my leg hurts, okay, where on the leg is it hurting? Is it in the joint area, which would be the knee and ankle or the hip where the area bends? Because that's more concerning to me than like a long, shin or tibia or that type of area. And are you stiff in the morning? Do you feel worse in the morning and then get better with movement? Are you slower in the morning? Are you limping in the morning? Is this progressively getting worse and you feel like nothing is helping it? We don't really have this yo-yo effect of joint pains getting worse, stiffness getting worse. It's worse in the morning and then gets probably a little bit better throughout the day, similar to adult RA patients. The thing with children is that they compensate really well. So sometimes it's hard to tell, like all kids are bouncy in the morning. Most kids are very active throughout the day. So it's hard to tell, when they're off. And sometimes it's just the subtle things. Like in the younger patients, I had a parent who said, my baby wouldn't let me move their leg when I was changing their diaper. So it's a very small thing. Or they didn't want to climb up the stairs to get to this. And that's like their favorite thing to go do is to go do this. And they weren't doing that. Or their teacher said that their naps are a little bit longer. So subtle things might be markers. So it's important to ask these questions at the first visit. Obviously, if there's swelling in a joint, there's redness, tenderness, that's worrisome as well. But the persistence of problems, seeing physical things like swelling not go away, that's worrisome.
And so, to put it in the context of this positive ANA, so what does that mean? So do you what blood work are we looking at?
Yes.
And then this positive ANA, what does that mean?
Ooh, the positive ANA, it really throws everything in. So the positive ANA is not diagnostic of anything. So even if I diagnose a child with JIA and they have a positive ANA, I'm going to say, okay, you have a positive ANA. That doesn't tell me that you have JIA. It just tells me actually in the world of JIA and ANA, what that tells me is I actually need to worry about increased risk of uveitis in the child. So the younger you are, the less number of joints you have involved. And if you're female, these are 3 things. And if you have a positive ANA, those are the combo of 4 things that actually increase your risk of having eye inflammation, anterior uveitis. Basically, that's inflammatory cells building up on the front part of the eyeball. And sometimes that's not so subtle where you and I or the parent can see it, but it really means that they need to go to an eye doctor to get it checked out, they do a slit lamp exam where they dilate it and they look at it to look for inflammation. Sometimes you can see things like the child might complain of like photophobia, where too much brightness is hurting their eye, or maybe it's a little bit red. They feel like a sandpapery, gritty type of feeling on the eyeball. So those are signs that uveitis might be kind of lurking, but most of the kids that have that positive ANA.
Okay, that's actually super helpful. Can you explain a little bit the risk of uveitis so that people can understand the because I think very often, and I see this with my own patients, right? Very often we have patients who have something, but they're doing better. But then they have this positive ANA, and you as a doctor, you're like, I know that this is important. You've got to see your ophthalmologist on a regular basis. But they're like, well, but my kid is doing so well.
Right.
So explain how you explain this to your patient.
So, okay, so that's good. So let me first talk about the ANA and then kind of go into the uveitis part. So when you have JIA, you're going to be classified into a subtype. Having that JIA plus an ANA is going to dictate how frequently you have to go to the eye doctor. There's guidelines by the American Academy of Ophthalmology that says every 3 to 4 months. Those are the high-risk patients, every 6 months or every year, depending on the type. That's just screening. It doesn't mean that you're going to catch it before it happens all the time, right? It's just in that window. But what I say is that uveitis can sometimes occur regardless of how well the disease is controlled. More likely to flare when everything is active. Like obviously your immune system is very active. Your eyes are going to be at risk for being involved. But even when things are quiet and you're in medicated or non-medicated remission, you still need to go to the eye doctor because this can march on its own. So that's kind of like it's going to be me and the ophthalmologist that are your best friend over the next 6-7 years that you're going to have to go see to make sure that this stays quiet. Because I have had kids that are in complete remission off of medications, and then the ophthalmologist will call me and say, they're flaring, they have cells in the front part of their eye, we're going to have to start them back on, whatever biologic that they were previously on. So I'm restarting the biologic on behalf of the ophthalmologist, not for the joints, but for the eyes.
Yeah, that's super helpful. Thank you.
Mm-hmm.
And and so does it happen to you to have, and I'm sure it does, but
Yeah.
you have positive ANA that leads you to a diagnosis of JIA. So meaning somehow some other doctors, and in the rheumatology world, like in the adult world, we see this often where some other doctor will, or some other specialist or non-specialist will check ANA just because they don't really know what's going on.
Yeah.
And then they send us patients with positive ANA. How would that look like?
I have never found a patient that I accidentally picked up on JIA with just a positive ANA, because JIA is a very clinical diagnosis, meaning my hands and what I'm hearing in the history have to equal. That's the most important part of getting that diagnosis. Again, the positive ANA is not going to make me think, oh, I should probably check for JIA. No, I'm already doing that in my head. I'm checking for every rheumatic illness I know of in my brain when I'm seeing a child or any patient, right, that comes to me. But if I see a positive ANA and I see joint swelling, I immediately kind of start educating on eye symptoms, because I mean, no one's going to mess with the eyes, right? You can go blind. Uveitis can cause you to go blind untreated. So it's one of those things where I'm like, this is important that we get you to an eye doctor right away, because their first line might be eye drops, whereas on the back end, we're working on getting bigger medications to get them off the eye drops. So it's a team effort. But never has a patient walked in with a positive ANA and then I'm like, oh, well, you have JIA. No, it's because they're calling with joint complaints, not feeling well, looking inflamed on labs, and they have that ANA that increases the risk of uveitis.
Yeah, that makes sense. I think it will be the same for us.
Yeah.
You're like, oh, and I tell this to patients all of the time. It's the diagnosis is mostly clinical, and then you look at the labs, right?
Yeah.
And so while the labs can confirm a diagnosis, you can have no labs positive and have a JIA or some other autoimmune disorder. So I think that's particularly important. So you're a little younger than me, actually, quite a bit. But for me, the reason I became a rheumatologist is TNF inhibitor, right? They started in the 1990s, and so we started seeing patients go from being crippled to a totally normal life. So I really like to show our patients how amazing our treatments are.
Yeah.
So when you have a patient with JIA, so first, my first question is, if they have a positive ANA, does that change your management, except for the eye exam? Do you go faster to a biologic? How are you? It's of course a case by case basis, but in general, what's sort of like the thought process in your mind about how you're going to manage someone?
So the ANA is not going to change my management of treatment at all. It might veer me towards like, okay, let's get you to ophthalmology faster. If I'm thinking of an overlap with JIA, like or like a lupus or mixed connective tissue disease, I might change the workup. But at the end of the day, what I diagnose you with is going to be a combination of the history, what my hands feel, and then maybe some of the labs. The labs for JIA, the most important ones are going to be rheumatoid factor, CCP, and then the HLA-B27 also in certain subtypes. ANA is just gateway to the ophthalmologist at this point. ANA and other conditions can be, depending on how high it is, then I might broaden the workup to look for lupus spectrum type disorders. But usually you get that from the history and from the exam. I'm not going to just look at an ANA and say, okay, now I should broaden the workup and look for this. It's not that, it doesn't work that way.
Totally. And in terms of treatment, so is there, like, if you have, do you start patients like us in rheumatology well, I guess, sorry, it is very interesting to always talk, like when I talk with you, because it's almost like JIA is just this huge umbrella of like almost every single inflammatory arthritis in rheumatology, like in the adult rheumatology world. So for me, my umbrellas are a little bit, under, like it's not right away on top, right?
Got it. Yeah.
So when I hear you, it's like JIA is here, autoinflammatory syndrome is here, and then you have those. But for me, it's like I don't have JIA because it's not juvenile. But usually, it's like, okay, rheumatoid arthritis, spondyloarthropathy, and like
Yeah.
define the and then autoimmune disorders such as lupus and MCTD and so on.
Right.
So I'm realizing that my question actually is really hard for you. Tell you, okay, how are you going to manage that in general? I'm realizing, well, you need to probably know which they are.
Yeah.
When you don't know, what do you do? When you're like, I don't know yet where they are going, if they are going to go more lupusy,
Yeah.
they are going to go more like spondyloarthropathy or more.
Yeah.
Or,
That does happen. That does happen sometimes, especially in kids with psoriatic subtype or spondyloarthritis, where the joint, like they have a finger involvement or toe involvement, and technically that's less than 4 joints, so they fall into that oligoarthritis category. But from my experience, I know that that's very specific to psoriatic subtype. So what I say is, hey, I'm going to treat you based on what I see, but I wouldn't be surprised if you switch classes from that JIA umbrella from here to here now. But treatment is going to be the same. Treatment is going to be the same regardless, because I'm going to be treating you based on your disease severity, not on the title of what you have. So because you can have HLA-B27, bad arthritis, but a knee is involved. So I'm not going to go, I'm going to be a little bit more conservative if one knee is involved versus multiple small joints or medium joints are involved.
Yeah, okay, that makes sense. So thank you so much. Is there anything that you think someone that's worried about JIA should know?
Oh, that's a great question. I think the biggest thing is to keep tabs on what your child looks like. So in the morning, take note of what they look like versus later in the day. Are they acting different at school? Are they limping? Are there any triggers to this? Is it more mechanical? Because mechanical would take my mind away from something inflammatory, right? If every time they jump their knee hurts, I'm not going to say, oh, you have arthritis of your knee. But so you have to look for patterns, triggers, what's making it better, what's making it worse? How do they respond to a leaf or Tylenol? Does it make it worse or does nothing? Are they waking up at night because of the pain? Are they having other symptoms because other than just joint pain? Are they having fevers, rash, anything like that? Or their eyes red, that's very valuable information to come into a doctor's office with, because they should be asking you all those on day one. Right. So that makes the process go faster. So then you could spend more time on the treatment and prognosis.
I love this so much. And so maybe to finish, to wrap it up, how likely are you to achieve remission when you have JIA?
Ooh, that's a great question. So I think in my experience, and I think most of my colleagues' experience, if you can treat aggressively and early on, there's good chance of remission within the first 6 months. I always say the first 6 months to a year of diagnosis is the most critical time. I don't have a crystal ball and obviously things might trigger the immune system to do funny things, but for the most part, within that 6 month to a year range, you should be headed towards remission, if not in remission. Some people, the course might be a little bit choppier, or maybe they get to partial remission, and then we either have to switch their medications or add on a different medication. But in my experience, most kids do really well in that first year if we stick to the plan.
And that word can scare people when we use aggressive. I'm also a very aggressive rheumatologist. What do you mean by that word?
So aggressively means, I'm not saying we use every immunosuppression known to man. It's just that we are matching our aggressiveness with the child's immune system disease. Like however bad their immune system wants to be, that's how aggressive I need to be as well. We need to play equally, right? Yeah. But it's important that for people to realize that just because I'm starting you on this medication, like a biologic or methotrexate, in my mind, my goal is to start you so I can get you off of it as soon as possible, or at least try to get you in remission, maintain you there for 2 years, and then talk about weaning it off. I'm not saying you need to be on it forever. I think that's where people get hung up. Yes, you're not on it for a week, but at the same time, it needs to be a certain period of time to kind of course correct that immune system. That doesn't happen overnight. And I think this is where we are kind of aligned, is that so many other lifestyle factors add to that component of inflammation that can tip the immune system to do weird stuff again, right? So you really do need to be mindful about how you're sleeping, how you're eating, how you're moving, cumulatively. You don't need to be perfect all the time, but cumulatively.
Yeah, the example I use is a fire, and I do think inflammation is fire, right? And that's our body's way of healing. And for some reason, in rheumatologic disorders that are inflammatory, we have a lot of inflammation because our body is trying to heal something. It's doing too much of that, and we have to help it. And I always use this idea of the fire. If you have a fire ongoing, you don't take a pipette of water. You don't just take a little bit of a glass of water.
No.
You take a ton of buckets, and then you back off and make sure that it stays moist so that there is no risk of fire again.
Right.
And I use that because it's so obvious. Then you're like, oh yeah, I don't want just a little bit of water. Let's put out that fire.
Put it out, yeah.
Well, then it's fine. Versus it spreads all over.
Yeah.
Then it's much harder to take care of.
Right.
Yeah.
Yeah, it's the control factors. Like, you can only control so much. You just need help sometimes with medications. And there are, I would say, more of a minority of patients who can get away with not being on medications, but that's not the majority. And the reality is, like, you're probably going to have to be on some sort of medication for some period of time, so we don't have these long-term consequences that I can't bring back, like eye blindness, or, flexion contractures where your joint doesn't move anymore as well as it used to. And for a child, that can be very, like, mentally an issue as well, since nobody wants to walk around with a limp in middle school.
Absolutely.
Nobody wants to look different, or have like smaller calf on one side compared to the other. You just want to be a fly on the wall at that age. So and we have to do a lot of work sometimes to keep it as invisible as possible.
Yeah. And I think it is. I think that in our world, we can really say that we have good chance with all of the tools that we have to get there. So Dr. Singla, where can we find you? If someone wanted to work with you, where can they find you?
So my website is www.rheum2growtx.com. Rheum is RHEUM. I'm also on Rheum2growtx on Instagram and Facebook, and Rheum2growtx, I think, on TikTok as well. So, if you want more education, feel free to binge my content there. Or if you ever feel like you're not sure if you're in the right place, or you kind of want an integrative consult, I'm happy to hop on like a free discovery call to see if it makes sense to work together. Yeah, and you can find all that on my website.
Excellent. And we will put all of this under our video. If you have found this video helpful, and if you think that this could be helpful to someone else, please share the video, the website, positiveana.com. Add comments and let us know what you think as well. If you have any other questions related to Positive ANA, please let us know. And thank you so much for listening. Thank you, Dr. Singla.
Thank you.